A lot of very good questions were certainly put down on paper, so that took me a few minutes to go through. Certainly some of these questions will be better asked or addressed during the breakout sessions. If there are very specific questions for ET or PV, do forgive me if I don't actually discuss the question here, but certainly there'll be more opportunity in the disease-specific session. We do have a good amount of time. We have till 3, so hopefully we can get through most of those. Our panelists joining us today, majority of them are here. Some of you had specific questions for specific people who may not be here. So again, we'll try to address as many as we can. Okay, with that being said, I think I'd like to start with a question about genetics, and this would be to Dr. Rezar. So the question says, are MPN genetic? Both parents had different blood cancers. So unrelated blood cancers to MPN, but the patient who's asking this question has an MPN. What's the relationship genetically in terms of not necessarily heritable JAK2 mutation, but the predisposition to having blood cancer in general, having an MPN when the parents have had blood cancers?
Right, so a really good question. Oh, okay. Can everybody hear me? Or is there a button to push? How about now? No? Now? Okay, great. So I'll just repeat the question. The question was, in a family, for example, if both parents had a blood cancer, not MPN, and an offspring has a JAK mutant MPN, what is the inheritance to that? So in general, for example, if one parent has MDS, we tell the offspring that they have an increased likelihood of getting a blood cancer. And what exactly that risk is, it's a bit hard to estimate. So similarly, if one parent has MPN, like my mom, as you heard in my presentation, I have an increased risk. It's probably not tenfold, but maybe twofold of getting a hematologic malignancy or an MPN. And so it's reasonable for the children of parents who've had a blood disease, or if both parents, to get a blood count every year. And then exactly what those genetics are, we don't always know that. For example, we talked about the driver mutations, and then there are the germline variants, some of which we know predispose to a MPN or clonal hematopoiesis. I showed you a slide, for instance, variants in the IL-6 receptor. It's an inflammatory cytokine you heard about. There are people whose receptor is hyperresponsive, so they have a more inflamed system. They're at higher risk for clonal hematopoiesis and MPN. There are people who have a blunted response, and so they may be protected. And so in the family that was posing the question, there may be something underlying in the germline that did predispose each parent and then the child, and we probably don't know what that is, unless there were really detailed genomics and something came up. But we have 30,000 genes, so there's still a lot to learn about what the other genomic influencers are.
So, Dr. Rezar, related to this question, and another question asks if the additional mutations that are acquired during the course of the disease and external influencers, how do they impact the acquisition of new mutations? So besides smoking, what are some environmental things that could lead to the acquisition of new mutations? Is the presence of a second mutation to begin with more likely to dispose you to get a third mutation, a high-risk mutation? Kind of what are the factors here that play a role in clonal evolution, I think is the way I would phrase it.
So another really great question, and also a big area of research. So if you already have one mutation and you get another, and there was one data slide where I mentioned about half of our MPN patients will have another mutation, and you all know how many times our hematopoietic stem cells are replicating, that's not surprising. And you also saw a really nice genomic slide, I think you showed it, where there were high-risk mutations, and patients who have more mutations are more likely to evolve and develop and expand a clone that might be deleterious. So, the question in general is more mutations, there's higher risk of expanding the clone and having progression. Fewer mutations, there's a likelihood of less progression. And that kind of data is a little bit hard to come by in MPN because these diseases, fortunately, our patients last can live very, very long. However, if we extract from, for instance, MDS, there are very clear algorithms. If you have 2 or 3, there's an 80% chance of having a malignancy in 2 years. Those are diseases that progress much more rapidly. And at least in that setting, the number of mutations and the type of mutations plays a role.
Thank you. So on the topic of mutations, I actually want to send this question to Dr. Ellen Ritchie, who's joining us, and we'll be speaking more about ET. But the question, I think, is not just ET related, but general to CALR mutations, both ET, prefibrotic, and overt myelofibrosis. How is CALR, ET, or MF different than JAK2 mutated disease? We talked a little bit about progression risk with CALR, potentially outweighing JAK2 progression risk, but having less thrombosis. How do you think about CALR patients differently in clinic, if you do think about them differently?
Well, I should just yell. Maybe better. So I do pay attention to CALR mutations amongst my patients, that there are some differences. CALR1, it looks like there is a higher risk potentially of progression. We may think of those patients as being more prone to a myelofibrosis-like picture over time. CALR, I think of as more, likely to sort of have ongoing ET. But it's a story that we're still at the beginning of. I always feel that let's give 20 years to a story and sort of see how it all plays out. But I do think very differently also about aspirin use amongst these patients, or how aggressively we may need to cytoreduce patients, whether they're CALR1 or CALR2 mutated. JAK2 mutated patients, those are patients that we worry a lot about thrombosis, and I think more about aspirin use, and is there any aspirin resistance amongst these patients. In all of my patients who are CALR1, CALR2, or JAK2 positive, I worry a lot about cardiac risk factors, and I see Dr. Feldman's at the end of the table. We don't have as much information as I would like to have as to how we treat our patients who have cardiac events, whether we're treating them appropriately, aggressively or not, or too aggressively, whether we're causing bleeding or not causing bleeding. So I look pretty carefully at all of these little variables when I am seeing patients who have CALR mutations. I'd say if I were to think roughly in my mind, it's really almost half of my patients are CALR and almost half of my patients are JAK2 mutated. There are a few triple negatives in there, and maybe I have 1 or 2 MPL mutations in there, but the majority are falling into either of those 2 categories. So you think a lot about what's the best way to treat my particular patient. So you were trying always to give personalized medicine, and I use that sort of with air quotation marks, which is, looking at their mutations, looking at their other medical problems, looking at their family histories, and looking at their medication histories really carefully, and trying to figure out what the best way is to treat that individual patient.
Thank you very much, Dr. Ritchie. Dr. Pemaraj, I'll ask you the next question. So since we're kind of talking more about personalizing treatment based on genetics, and CALR came up, you did in your talk about the novel approaches targeting CALR, and certainly there's some novel approaches targeting JAK2, the type 2 JAK inhibitors. So since clinical trials and novel therapies was really the premise of your talk, I think you're probably best suited to address the question of how do you see the treatment landscape changing in the era of all these new drugs, and how do we choose, how do we sequence drugs? I think it's probably a tough question to put you on the spot there and have you answer. But
I only need 20 seconds. It's very, Rajit said it's simple but not easy. Great question, and a couple of folks asked me in the audience as well, similar. So maybe 3 practice pearls for everyone to take home on this one. Number one, even in this group, I think we have to say one fact. The ruxolitinib and the other JAK inhibitors that are available, so fedratinib, pacritinib, momelotinib, right, these four, they are JAK-STAT inhibitors. So that means that they hit the pathway, not mutation specific. So somebody asked me recently, hey, why are you so excited about mutant JAK2 inhibitor in CALR? That's the first time we have precision oncology where we're actually targeting a mutation. Okay, so these drugs available are wild type is the word they use that hits the pathway, not just the mutation. Okay, so that's why if you're MIPL or CALR, you still can respond to a JAK inhibitor. They're not JAK mutant inhibitor. Okay, so that's number one. I think very important. Okay, number two, for the mutant JAK inhibitors, right, so now there's two classes of this, which are very exciting. The first one is by the Ajax team, which is here in New York, started by our colleague Ross Levine at Sloan Kettering, which is a type 2 specific JAK inhibitor. So maybe these ones that we've had so far are a certain type 1, and it has to do with hitting the inactive versus active conformation. But anyway, basically hitting the molecule in a different way. And so that's called type 2 JAK inhibitor, what you nicely mentioned. And then Incyte has a mutant JAK inhibitor coming that's already available in clinical trials, phase 1. Again, you should have had a JAK inhibitor, and now we're going to try to target the mutant. So that's exciting. What's the point of it, I guess? The 2 points would be by hitting the mutation specifically and not just the pathway, can you minimize toxicities and can you maximize damage to the cancer clone, rendering it finally come down to zero, right? We haven't done that yet. We're trying to do that. And so I think those are the two things. Those are phase 1. We're still in the early stages. For the CALR, maybe the third point, very exciting, right? So this is our approach now to finally harness immunotherapy. So you've heard about CAR T cells in multiple myeloma, lymphoma, leukemia. What about us? Our European colleagues are working on the constructs for the first ever CAR T cells. Those are chimeric antigen receptor therapy where you're taking your own T cells to then attack the CALR. In the clinic, I showed you there's vaccines, there's the bispecific molecule and the monoclonal antibody. Again, you should have a CALR mutation, have had at least one prior therapy, and you mentioned this yourself nicely, that CALR is in both ET and MF. So these should be not PV, ET, MF, directed against the CALR. And somebody asked me, do you have to have a big spleen for all these trials? Almost all of them we used to, but some of these new age trials, take a look. We're trying to be more flexible to allow patients, maybe not necessarily with splenomegaly, but also with the mutation. So sometimes that can be a benefit to our patients. So I think those are the 3 points.
Excellent. I will give a follow-up question on the same topic. Do you envision that these therapies could move us towards having one treatment as opposed to combination treatment being the appropriate approach? Because now we have clinical trials that talk about combination therapies, are studying combination therapies, and have shown promising data, better than single agents. Do you foresee that having some of these precision approaches perhaps would forgo the need for combining and adding more treatments and actually help our patients?
I hope so. I mean, we're far from that, so I can't say definitively yet. But the 2 points that you're making are so smart, right? One is that I'm not curing you by giving you these pills so far. So allogeneic stem cell transplant, as we heard earlier, is the only curative modality in 2024 period for these diseases. We're not doing it for the early stage because the risks are still so great, but if you have intermediate to high-risk myelofibrosis. In the absence of transplant, which really the vast majority of people don't qualify for, I still think we're still searching for your answer. So if it comes in the form of combinatorial therapy, as long as we make sure that you're living better and longer, let's take it. If it ends up being one of these predator, these kind of specific attacks on the cell, as you say, the specific precision, we'll take it. I think that's the importance of why we're meeting here. These clinical trials are important. You never know what's going to hit. You never know which trial you volunteer for is going to work. But I can see these as two separate arms of what we're trying to do. And until we have a winner, let's try all of these. So that's kind of my answer.
Yeah, thank you. Thank you for that. Dr. Mesa.
I just want to make one comment as a veteran of many of these sort of events. So an additional way of looking at it is these are kind of multiple options kind of competing with one another. But still, we don't know for certain whether they're better than the options that we have for certain individuals. So I just caution that, because I know people leave an event like this sometimes and, boy, I'm perfectly stable on interferon, but now I'm terrified that I'm not on the CalR study. And that's really not the way to look at it. The hopeful way to look at it is, again, I'm stable, which gives time for all of this to really work itself out. Because I'm incredibly excited about CalR as a potential target. However, my enthusiasm of one approach to CalR versus another, isn't there yet, because we don't know. We have a couple options. They're very early. There are multiple other ones kind of in development. So, if you're stable, look at it that, when something is really transformational, you will have the option to have it, no question, whether that's in a trial or whether that gets approved. And really the best situation is you really go from being perfectly stable on one option until your doctor says, boy, this new drug has been approved and it's so helpful that then I should be switched over to this other agent. That's really the best case scenario. The trials fundamentally, although they're very exciting and sexy and interesting, are really for where, boy, the current state really is not working for me. Or the other types of studies, which are less common, but again are for the untreated patients, and that typically is a fairly high bar in our world, where we have one option versus the other with the untreated patient. There's a fair amount of confidence that the second approach being compared to the standard is probably at least going to be no worse, so that things are not compromised. So all these things have all have kind of a time and a place. And again, sometimes I know the distress of watching the sausage be made can be too much for folks. Oh my gosh, there's so many trials. Can I be on all of them? There's a time and a place, and that's why it's always a very active discussion with your physician. Is this a time to be considering a trial? Is there an appropriate trial? Or sometimes trials are not an option, but that's actually a good thing, because things are so stable. We wouldn't want to introduce additional risk for the patient who is stable.
Thank you, Ruben. That actually answered the next question, which was how to consider combination treatments. When is it worth trying? What symptom condition risk factors should be considered? So that question is now answered. But it's a nice segue to hand this over to Dr. Hasselbach, because there's a question specifically to you and about statins. So I think maybe I'll reframe this into a twofold question about combinations. So when do you consider adding a statin in your clinic? What would you tell patients and how to approach the topic of adding a statin to their regimen when they go to their doctors? And also, the second part of the question is, when do you add ruxolitinib to interferon? So unrelated, but two questions.
Thank you. The first question in regard to statins. Can you hear me now? Yes. The first question in regard to... Hello? Can you hear me? Good. The first question in regard to statins, plus minus. Last year I had this question, and I was a little saying, oh, let us see. I will answer you next year. And this is today. I am convinced that statins benefit patients with MPNs. Why? We have shown that use of a statin in the background population protects against development of MPNs. A large national registry study showing this. Next, we have shown most recently in regard to interferon that our population of interferon-treated patients in our outpatient clinic, I asked a medical student to make a research collecting all data on these patients, and the research question was, does a statin enhance the efficacy of interferon? And for sure it does, and it has just recently been published in British Journal of Hematology. The JAK2 kinetics in those where we have added a statin is much more rapid than without a statin. And then you can ask the question, why? Again, I am convinced that the most important thing in this context is the fact that statins are not only cholesterol-lowering agents. They are actually also potently anti-inflammatory. That is my first thing. The second is that a Danish research group led by Nordesgaard at Herlev Hospital several years ago showed in New England Journal of Medicine, a high-impact journal, that in statin users, the cancer-related mortality is decreased by 15%. And what does this tell us? It tells us that statins are also, in some regard, anti-cancer agents. And it has been shown that they inhibit cancer growth in certain cancers. And in regard to, and that is a very important thing, in regard to JAK inhibitors, ruxolitinib, raises cholesterol levels. This has been known, and you know also that weight gain is a problem. So in that setting, statins, of course, should be used because also statins actually have a synergism with JAK2 inhibitor. So there are so many, I think, sunshine stories in regard to statins and MPN disease. And I will just close my comments here saying that statins are also potently dampening white blood cell count activity. You know that the white blood cell count, the white blood cell is activated as part of the disease, and it dampens it. It also dampens platelet activation, and it also dampens endothelial cell activation. And what more can you want in a disease like MPNs? So to conclude, today I will tell the patient, are you on a statin? No. And then I tell the patient, I think that you should go on a statin. I have not finalized this because years ago we tried to set up a statin study in Denmark. Actually, 10 years ago, 15 years ago, we tried to set up a statin randomized study with the UK. Impossible. Simply because every third patient was on a statin by the cardiologist. So you couldn't go that way. But now we are very close to launch a study where we, only in 40 patients, because it is a proof of concept study, where we add atorvastatin 80 milligram. And then we follow the patients for half a year, trying to look at the JAK2 kinetics once monthly, try to look into gene expression profiling studies, studies of circulating cytokines, inflammatory cytokines, etc. So I hope that if we meet next year, I will have preliminary data on this.
Terrific. Thank you, Dr. Hasselbach. Statins are getting a lot of airtime, so I'm actually going to ask a little more about statins, question to Dr. Feldman. The question is, I'm going to refer you a patient now who may have been on ruxolitinib, may have gained weight, may have had metabolic abnormalities, or none of the above. From your perspective as a cardiologist, what factors into your decision about starting a statin, and not just about LDL triglyceride, which I think somebody's interested in hearing about triglycerides, but what else do you factor in the decision of starting a statin, particularly knowing the anti-inflammatory effects, the other cardiovascular disease risk factors that are not related to lipid or cholesterol abnormalities? What are your thoughts on that? And which statins would you choose? Does it matter which ones you choose?
Well, can you hear me? So first, as a cardiologist in this audience, it's awesome to hear oncologists so excited about statins. So it's, I usually get along better with the oncologists anyways because of the nature of what I do, but this is really exciting. Now I have evidence to prove that my patients should all be on statins anyways, where I joke with patients in the office that we probably should just have statins in the water, but anyways, before we do that, plus an SSRI and antidepressant, we won't go there. But to get to your question, so the traditional cardiology approach to you referring a patient to me would be to say, okay, well, what is your 10-year cardiovascular risk? And should we be thinking about putting you on a statin? Because that's traditionally what we do for all patients, regardless of cancer history. And so for that, we will check your lipid profile. It does not need to be fasting. The only thing really impacted by fasting is your triglycerides. But otherwise, so it's fine whatever time of day. I would rather some data than no data. And we do look at that lipid panel. And then based on large pooled cohorts, we can calculate your 10-year risk of having a heart attack or a stroke. And so this factors in your age, your ethnicity, your blood pressure, let's see what else, diabetes. And so that will give us some estimate. I will tell you, this comes from my big societies, the American College of Cardiology, the American Heart Association, and with that, there's a big asterisk for risk-enhancing features. And so risk-enhancing features are things like HIV, we know, increases risk for cardiovascular disease, chronic inflammatory processes. And so in my mind, a patient who has MPN, a patient who has the CHIP mutations, that falls into the risk-enhancing calculator. So I would plug their information into a calculator and decide whether or not they meet the threshold 7.5% risk over 10 years or not to put them on statin therapy. If they don't meet that threshold, which most people usually end up doing, then I will look to see if, as part of your workup, you've gotten a CT scan for the patients. And this is where I was talking about looking for atherosclerosis. To look at your CT scan of the chest, I will put it in the bone window with you in the office. We'll take a look at your heart arteries to see, is there plaque buildup there? If there's any calcium there, that suggests you do have coronary artery disease, not necessarily blockage of the plumbing that's going to cause symptoms, but increases your risk. And so then I would say there's evidence there, regardless of what your LDL is, that we should have you on a statin. Let's see. So that's a little bit how I would think about it. There are some other situations, not in the MPN patient, but where we have seen statins have impact on cancer outcomes. This is we see in triple negative breast cancer. We call it almost like the reverse cardio-oncology, meaning if we give you a statin, it has better cancer outcomes, similar to as you're describing with MPNs. We also see statins being used for protection for some cancer treatments that can traditionally cause heart issues, such as if you've ever heard of anthracyclines, doxorubicin can traditionally cause heart issues. There's data to suggest if we give you statins, and the type of statins are the lipophilic statins, which are like the atorvastatins, the Lipitors, tend to have some protective benefit. That's clearly not the LDL lowering. It's something about the anti-inflammatory or other, some protective, I call it like we're not totally sure. I do a lot of hand waving about it, but there is clearly some benefit to it. And so which statin? Well, I usually try to use the lowest dose possible to minimize side effects. The highest intensity statins are the Lipitors and the rosuvastatins, the Crestors and the Lipitors of the world. And so the highest dose you can use is 40 and 80. I try to use something less than that and make sure you're not having side effects.
Excellent. Thank you very much. All right. So next question I will give to Dr. Hoffman. Dr. Hoffman will be speaking about myelofibrosis in the disease-specific breakout sessions, and some of these questions might be a little too specific, but I'm going to make this a little more general. The question was asking, can you talk about the differences between primary and secondary MF? And what are some similarities? What are some differences? Do you think about, a different timeline for treatment, intervention? How do you think about transplant as a sort of a consultation or really a definitive therapy for either of these two diseases, or I guess three diseases when you're talking about secondary versus primary MF?
Well, obviously that's can you hear me? Yeah, that's a very complex question. So, there are two forms of myelofibrosis. One is that which occurs de novo, either in an early form of the disease called pre-myelofibrosis or cellular form of myelofibrosis, cellular form of myelofibrosis, where the patients closely resemble essential thrombocythemia, and some of those patients go on to develop overt forms of myelofibrosis. And we only transplant those patients who have intermediate to or high-risk disease, which you've come to the session. I'll try and explain to you in language that you can understand, and hopefully I can understand. PV-related and ET-related myelofibrosis is different because it's genetically much more diverse in that it involves calreticulin and also MPL mutations, and there's a higher incidence of triple-negative disease, and frequently there's a higher rate of transformation to overt myelofibrosis. One thing that everybody has to sort of realize is not everybody evolves. And we have followed, or I have followed, patients for 30 or 40 years with these myeloproliferative disorders who never evolve. Or if they evolve, they slowly evolve. You know, so one has to closely watch these people, basically in order to determine what the biology of the disease. And there are metrics by which you can assess the risk of somebody going into transplant. But in the best centers in the world, one has to realize that 1 out of 5 patients who go from transplant are not going to make it through transplant. So that's a reality. On the other hand, you can look at it that in the best of all conditions, 80% of the patients are going to be cured of the disease. But the first year is going to be a really tough year. And I think you have to make that sort of clinical judgment. And what we do at our institution, at least what I do, I'll speak for myself, is I very closely follow the patients in order to be able to assess the biology of the disease, understand whether the patients are becoming more symptomatic, whether they have more blasts in the peripheral blood, whether they're acquiring cytopenias, increasing splenomegaly, losing weight, because you don't want to lose that window of opportunity where somebody can go for transplant. And that's a decision that one has to make with the physician, with the patient, and their family, because it's really a commitment not only for the physician, that's the least of the commitment, it's for the patient and also the family, because the patient's family really has to support these people during the post-transplant and during transplantation. So it's a really tough decision. And, you know, those patients who have PV and ET-related myelofibrosis appear to progress a bit quicker. But, you know, we've had patients, I have a patient, for instance, who I've followed now for almost 20 years, who they tried to transplant. One of my colleagues tried to transplant 20 years ago because she fit criteria for transplant. She would have none of it. She was involved with continues to be involved in the fashion industry. She said no. And I thought she was crazy, but she still continues to live to this day and have a very high quality of life. So you really need your doctor to slow it down, assess what your risks are, assess what the benefits are, and then see how rapidly your disease is progressing. And then if there's no other therapeutic options, you don't want to wait too late, you know, because then you're going to lose your window of opportunity. If you go into MPN blast phase or accelerated phase, you know, I'll talk today about that. We do have some new treatments for that, but it's much more difficult. So I think this is a core question that is frequently not discussed because people don't really want to discuss transplant, but that's really our best treatment in October of 2024. That is our best treatment.
Thank you,
It's our
Dr.
only
Hoffman.
curative treatment.
So I think you've answered the question of whether we're waiting too long to transplant. I think the answer is yes and no. It really depends. So it's
Well,
an
I think
important.
that depends upon the center and how closely you follow the patients.
Yeah, I think certainly getting that visit with the transplant physician, I think, is important to establish at some point during the course of myelofibrosis, preferably earlier. Whether the decision is to pursue it or not is a different question,
Right,
but
so
getting the
that's
information.
an important question. That's an important point, because when we see a newly diagnosed patient with myelofibrosis, the next appointment is not only with us, but with the transplanter. So it's at diagnosis, because we want to know what weapons we have, what's in our armamentarium. So I wouldn't wait till you're really sick to see a transplanter, that's for sure. You want to know what your options are. Do you have a donor? How good is the donor? What's your shape? And hopefully with the new drugs that Naveen discussed, we can put transplant on the back burner and not use it. But right now we don't have that luxury.
And I do want to ask Dr. Feldman a question about cardiac assessment pre-transplant. But before I do, I'm going to send a question to Dr. Silver. Dr. Silver, we talked a lot about really the quote-unquote guidelines of treating patients and sort of the risk-adapted approach to therapy, determining risk and then deciding what's appropriate. As somebody who has been on the ELN committee and multiple committees for where these guidelines really stem from, I think the group would like to hear from you. What are your thoughts about current guidelines about watch and wait in general applicable to really ET, PV, and MF, if you can address each separately? What are your thoughts about a watch and wait approach? I think I know the answer to that, but I want to see, I'm sure the audience wants to hear it from you as well.
Well, thank you for that. Can everybody hear me? No. So the question is, what do I think of the guidelines?
About watch and wait specifically.
Yes. Watch and wait guidelines. So in the United States, and Europe, there are two consensus groups for clinical treatment of the MPNs. One in the United States is known as the NCCN, and some of our members of this panel are illustrious members of that group. And in Europe, the Europeans are very well organized, I think even better than in the United States. In the European Leukemia Net, I think Dr. Hasselbach is a member of that. And they have promulgated guidelines for the use of practitioners. And low-risk patients in both groups have been advised to follow a watch and wait policy unless the disease overtly progresses or unless symptoms develop, as so beautifully articulated by Dr. Mesa and Dr. Panaraju. Now, you also have heard amply this today from Dr. Rosar and Dr. Hasselbach and Naveen why these diseases are genetically and molecularly active. So it really doesn't follow that one should really watch and wait these diseases burn up the house while it is still confined to the first floor. So we at Cornell, I know Dr. Hasselbach in Denmark represents a group of individuals who believe in treating these diseases when they're diagnosed. Now, what you treat them with is a matter of judgment and evidence and what you believe the literature shows. And you've heard some of these very, very experienced hematologists issue caveats that you don't jump into the first new drug that's available. You don't necessarily change what's working, et cetera, because they have a vast experience. That's why they're here, right? Thank you, gentlemen, ladies and gentlemen.
Thank you, Dr.
So in answer, we believe that the guidelines are probably too conservative, that we believe and we represent a group that believes in actively treating disease. And somebody this morning, I forgot who it was, but pointed out to about the REVEAL study. It's what is actually happening around the United States. Dr. Mesa is a co-author of that paper. And unfortunately, the great majority of people do not get what we would consider optimum treatment of any of these diseases, particularly polycythemia vera, which you will hear about later on.
Excellent. Okay, so I'm going to go back to Dr. Feldman and two questions. One is, let's talk a little bit about, pre-transplant cardiac workup. What kind of tests do you do? What do you look for? When do you feel like the tests become outdated if somebody's kind of waiting without getting a transplant, but then time comes for a transplant? Should they repeat these tests? And then the second question, which is unrelated, is about caffeine consumption drastically impacts my blood pressure. I typically consume a low amount of caffeine throughout the day. Would such a lifestyle have negative long-term implications? So caffeine maybe first and then transplant?
Sure. And since you've given me the microphone, I'll say, back to your initial statin question, the other thing to remember is that statins are cleared by an enzyme in the liver that many other medications are cleared by or can be impacted by. So they have a lot of drug interactions. We learned this a lot during COVID when patients are getting treated with Paxlovid, which can have tons of drug interactions. So the other thing, if you send me a patient, is I usually will send a message back with my note and say, are you okay with a statin? Or if they're in a clinical trial where I don't know enough about the mechanism of action of what treatment they're on, I want to know about the drug-drug interactions. So that's the first point. I'm always in favor, as long as it's okay with you. Caffeine. So I would say, like most things in life, caffeine in moderation. The most time that we talk about caffeine in cardiology is if people complain of or mention electricity issues, palpitations, feeling the heart beating fast. Then we'll usually talk about cutting back on caffeine, though there's not great evidence to support that caffeine induces arrhythmia, but it makes us feel better that if it's a stimulant, perhaps it's increasing the heart rate and causing more symptoms. Similarly, caffeine as a stimulant can increase the blood pressure, same way that smoking a cigarette would, and so which is why we would say probably don't take your coffee and then check your blood pressure. So if you're finding blood pressure issues and you're drinking 4 cups of coffee a day, and you may want to cut back a little bit. So I'd say in moderation. That's caffeine. Bone marrow transplant. So previously, there was not a lot of literature or guidance about what we should do in the pre-bone marrow transplant period as cardiologists. I would say I think about bone marrow transplant the same way as a cardiologist I think about getting ready for surgery. So if anybody's seen a primary care doctor, a cardiologist before surgery, you need that pre-op clearance. And so what's involved in that, and what does the data say? We have a lot of data about this, is that during the period of anesthesia, of having surgery, so for bone marrow transplant, it's getting pretty strong chemotherapeutic agents, getting a lot of fluids, potential risks for infection because of the immunocompromised, a risk of high heart rate, risk of low blood pressure. All of those things put stress on the system, and the cardiovascular system. So I say everybody is at risk with a transplant of having a heart attack, an arrhythmia, or developing congestive heart failure. And so trying to think about getting you ready for transplant, I want to make sure that when you step into my office before your transplant, we're not missing any undiagnosed cardiovascular disease, meaning, is your blood pressure well controlled? Are you in overt heart failure? Do you have swelling in your legs? Are you waking up at night short of breath because there's fluid in your lungs? Those are the big things that we want to pick up on. Are you having anginal symptoms, chest pain or shortness of breath when you walk? The litmus test, and my team of nurse practitioners is here, and we'll tell you that we want to make sure you can achieve 4 metabolic equivalents. Well, what is that? Can you go up and down a flight of stairs without chest pain and shortness of breath? Can you walk several blocks without getting anginal symptoms? If you don't have those symptoms, I don't usually feel strongly about doing additional testing beyond just a basic screening ECG. And then depending on what treatment you've had in the past, and usually we'll want to know, what does your pump look like? What's your ejection fraction? So we'll do an echocardiogram. For some other types of cancers, you're getting more cardiotoxic therapies, and so we're going to want to see an echocardiogram more frequently. However, your question about how often. So say I see you for pre-bone marrow transplant risk assessment, and you're waiting because we've decided that you're not ready for transplant yet for whatever reason. It's probably a good idea to be reassessed at 6 months to a year, depending on your clinical course, to make sure we're not missing something. But there's no set guidelines about doing, EKG echo stress test every X period of time. The only other thing I will say is there is some data out about risk stratification for bone marrow transplant for cardiovascular risks with transplant. It's the CARE BMT score. I'm a big fan of scores or trying to help give numbers or something besides giving you a vague, you are at risk. And so based upon your age, the type of transplant you're having, so an MPN, we're always doing an allo transplant, you're not getting a self transplant. That carries higher risk because you require more immunosuppression to get somebody else's cells. It depends on your ethnicity, your kidney function, your baseline cardiovascular risk factors. And based on large cohort of data, we can predict if you are low, intermediate, or high risk of having cardiac issues with transplant to give you a little bit more of an informed decision for you, for your oncologist, and the transplant oncologist to make a decision.
Thank you very much. That was very comprehensive. And no, very good. Thank you. I think we have time for one more question maybe, and I think it's an important question because it's about symptoms. So I'll send this your way, Dr. Mesa. And the question says, there hasn't been much discussion about mechanisms that may influence external symptoms other than inflammation. Are there other mechanisms?
Yeah, it's a good question. So I'd say there are several. First, the blood counts really do matter. So elevation in the blood counts or really decreases in the blood counts both can really contribute to symptoms. So elevated platelets, elevated white cells certainly can be linked to kind of compromises in circulation, not necessarily extending to a blood clot, which is kind of the extreme where there's no circulation. But without question, higher counts can impact things such as headaches, migraines with aura. People will comment on difficulties with concentration. I have patients who are hematologists who said, boy, before I had the disease, I thought that your platelet count didn't matter. And now I have the disease, and lo and behold, I guess it does, where they can, again, notice a real difference with their counts being better controlled. So one, there really is a circulatory piece. Two, there are symptoms such as the itching, where there's multiple different types of evidence suggesting that migration of white cells, there's been papers that have been basophils or monocytes, different types of white blood cells, can migrate to the skin and potentially have kind of a direct effect on the dermis. People have noticed, again, this issue of sometimes either temperature or water kind of triggering itching, whether there is this physical kind of reactivity of the white cells kind of in the dermis that is probably a piece of that. That's why there's one therapy that sometimes helps with really difficult itching has been therapeutic UV light. Now, unfortunately, it still comes with a risk of UV light can be damaging to the skin in terms of risk cancer, in terms of skin cancer. However, it really can help to alleviate that. So sometimes we'll use it, but really for a limited period of time. If people have really severe itching, we'll use that, but as a bridge to medical therapy to really try to control that better over time. Undoubtedly, the spleen and the enlargement of the spleen can really help to contribute as well, kind of independent of this issue of inflammation. And it's not, and I'm sure my colleagues can really attest to this, it's not a direct one-to-one correlation with necessarily this exact size of the spleen. Because certain individuals will have a big spleen and they don't notice it to a great degree, and others may have a smaller spleen but have more symptoms. And it may have to do a bit more with kind of their own individual anatomy. The spleen is a kind of a regularly shaped organ. It may impact people in slightly different ways. And some people might have sharp pain with a spleen that's smaller, perhaps greater sensitivity to kind of the nerves in the kind of the capsule of the spleen, where others sometimes can have massive spleens really without. And then finally, there really can be symptoms that have been associated with, let's say, kind of the biological consequences of having had the MPN. So for example, people that have had kind of a series of blood clots to the lungs that sometimes have not been identified can have what's called pulmonary hypertension, where the lungs can become stiff and have difficulty kind of receiving the blood, and that can lead to a whole series of difficulties, as well as individuals that have had blood clots to obviously the brain or to the the skull, the sagittal sinus, or to the portal vein or the circulation in the liver, sometimes can have a range of difficult kind of chronic symptoms really associated with that. So inflammation clearly is part, but not the whole story.
Excellent. This was terrific. Thank you to really all our panelists and our experts here for their time. We truly appreciate you being here with us.